Afternoon, everyone. Welcome to the second meeting of the Aging in Place Working Group. I'm State Senator Spiros Manzavinos, one of the co-chairs, and it's my pleasure to welcome everyone back this week. I'm going to just briefly allow members of the working group to introduce themselves again for many of the participants who may not have been on the call a couple weeks ago, and I'll just point out to folks as I'm call you out as I go around the screen here, but I will first go to my co-chair, Representative Krista Griffith.
Good afternoon, everybody, and thank you very much, Senator. Looking forward to joining our second meeting, and I represent the 12th district, which is in northern Newcastle County. Thank you.
Thank you. Just make sure. Wendell, you're on mute. Not yet.
There we go. I'm sorry. Yes, glad to be here representing the AARP for the state of Delaware. Thank you.
Awesome. Jean?
Sorry, had a little trouble. I'm Jean Mullen. I am the executive director for the Delaware Association of Home and Community Care, and we represent hospices, skilled home health agencies, home health aid only agencies, and personal assistance service agencies.
Thank you. Melissa.
Hi, good afternoon, everybody. I'm Melissa Smith, Division Director of the Division of Services for Aging and Adults with Physical Disabilities. Nice to be with you on this fine afternoon.
Thank you. Lisa. Uh-oh. Lisa? Oh, no. Give us a sign, Lisa. Uh-oh. Okay. we might have some technical difficulties with Lisa there. It looks like she's got. Okay, you're there. I see the raised hand. Oh, we can't hear you. Oh no. Okay. It's okay. Nothing. We'll have to double check here again. It's Taylor or Caitlin or William, see what we can do technically here. Let me move on to Katie.
Hi, good afternoon, everyone. I'm Katie Macklin. I represent the Alzheimer's Association in Delaware. And the Alzheimer's Association, we certainly are striving to realize our vision, which is a world without Alzheimer's and all dementia. So we work to accelerate research, drive risk reduction and early detection, and maximize care and support for all those affected Delawareans living with the disease and their caregivers. And I'm happy to be here.
Thank you. And we have two new members who just got word that they are appointed by the governor to be part of the task force. Chris Fraser.
Hi, thank you, Senator and Representative, for spearheading this, and everybody. And I'm pleased to be joining. I am dad at home today because mom's at the doctor. So somebody may be climbing up here. This is Eliza Jane. I work at Westside Family Healthcare. I'm the Chief Operating Officer, and I am pleased to be here as we consider all of the communities that we serve throughout our state. I also have the privilege to serve on the Board of Directors for Christiana Care Home Health. Hold on one second. And really appreciate the work that team does in reaching out and providing care in people's homes throughout the state. And I'm also excited to be joining, as I've been working with my parents as well on their journey on aging in place. So I hope that I can be a helpful member to this committee and learn as well. Thank you.
Thank you so much. Maggie?
Hi, everyone. I'm Maggie Webb. Thank you for changing my name. I could be Verna today. That's totally fine. I work at Easter. I know, she's a great person. I'm the Vice President of Programs at Easter Seals. I work with our adult day health programs and our personal attendant services in our agency with choice. So those individuals out in the community. So I've been working with the aging population for over 20 years. It's where my heart is. So I'm excited to be here.
Thank you. And we'll try Lisa one more time. How we doing? Let's try Lisa again. No? Okay. Oh, Lisa Zimmerman. Okay. So thank you, everyone. We do have others who are on the screen who will be presenting today, and we'll introduce them as we come up on that. So I just want to kind of talk about what we're going to do today. As you can see on the agenda, we have two presentations, one on national best practices, policy considerations from Jennifer Malinsky, who's coming to us from the Joint Center for Housing Studies at Harvard University, and also a presentation on recommendations for Delaware's DHSS with Martha Roherty and Adam Mosey. So I welcome them, and they will be speaking shortly. So what we'll do today is go through those presentations. We will, as we discussed in the first meeting, we are going to be breaking up into subgroups to allow this working group to take some deeper dive into some of the policy areas, and we'll be able to look to fill out those subgroups now that we have all the appointees by the governor. So we'll be looking to make sure that those groups are made up and get them on their way as well. So so the next order of business will be review and approval of the minutes from 2 weeks ago. I'm just going to make my first comment. It's just going to be William or whomever is doing the minutes. If you could please, on the members present, list their affiliations as well as the particular role they've been assigned to pursuant to the concurrent resolution that created this working group. So if you can just in the future, just be sure to add that so everyone's aware of where everyone is, who each individual is representing.
Duly noted.
Thank you. So is there any other questions or comments regarding the minutes from the last meeting?
Motion to approve.
I have a motion from Representative Griffith. Is there any? Do I have a second, please?
I'll second.
From Katie Macklin. Thank you. All those in favor? Aye. Any opposed? Great. Thank you. And again, all the documents, the meeting minutes, as well as other documents that are created are publicly available, through the General Assembly website for anyone who is watching and who is following along will be able to access that. And I think we should, at the end, we'll again list is that just on is there a specific website, or is it just going through the General Assembly website where people can find that information? Just remind me again. Caitlin.
So if you go to the committees page of the tab on the General Assembly website, there's a tab called All Task Forces, and there you can find the specific link to the Aging in Place Task Force webpage.
Great. So we'll make sure that that's available again for folks who are participating on the working group or those who are following along going forward. So at this point, I'd like to move to the next part of our agenda, and that is the presentation from Jennifer Malinsky, who's from the Joint Center, like I said earlier, from the Joint Center for Housing Studies at Harvard University. So I welcome you and thank you so much for speaking to us today, and we all look forward to hearing some national perspectives.
Thank you, Senator. It's a pleasure to be here. I'm going to share my screen and sorry. There we go. Okay, so great. Thank you for having me today. The Joint Center is we're a 60-year-old housing research center at Harvard, and we've been focusing on aging and housing for 8 years or so now. And we're just about to officially announce the Housing and Aging Society program within the center. So it just has become a really important focus of our work because of all the trends that we see. I am going to talk today about home and community services. I'm happy to answer questions about other national trends like accessibility, affordability, anything like that. So I'd be very happy to take those questions at the end. I'm going to talk, before I launch into the programs, let me talk for a moment just about 3 trends that I think inform the need for programs. One is that we know the older population is growing, but what's I think very significant is in the next 20 years, we are going to be seeing a doubling in the number of households headed by someone 80 or over. And that's really quite unprecedented. The oldest baby boomers are now age 74 or 75. And when we get into the next decade, when they're in their 80s, that's when we really begin to see the need for home-based services, for accessible housing, grow, affordability constraints grow even more. The oldest adults are more likely to be unaffordably housed. And so I think we are just on the cusp of seeing a great increase in need for the kinds of things that we'll talk about today. The other thing that's significant is that many of those folks will live alone. So the share of people living alone increases with age. 57% of those 80 and over live alone. Among those 65 and over, many live with a spouse, many live alone, and some do live with family, which I'll get to in a moment. But we're going to see about 10 million people living alone in their 80s and 90s and beyond in the next 20 years. And then finally, at the same time, we're seeing a different trend. We're seeing more multi-generational households. So all in all, 20% of older adults live in some kind of multi-generational setting, either in their own home where their adult children and grandchildren live with them, or they live in the home of another person, of another relative. Multi-generational households are obviously more common, as this chart shows, among Black, Hispanic, and Asian families than among white families. And that's likely due to cultural reasons and economic reasons. But as we grow more racially and ethnically diverse, we may see more multi-generational households, depending on economic need and whether those cultural norms persist. So the housing needs of a multi-generational household and a single person are obviously very different, but I think very important for us to consider both. Successful aging in place relies on many policies that I've listed here. And I was really pleased to get the working group's definition of aging in place, because I really think it's important to define specifically what we mean. It can have many meanings to many different people. But your definition seems to be about choice of where you live and the opportunity to live in the home of your choice, the community of your choice for as long as possible. So making these things possible, I think, takes all of these things. And I will focus on home and community-based services, but let me just stop for a moment here and say that services delivered in the home will be far less effective if that home is inaccessible to the older resident. An inaccessible house makes the job of a caregiver more difficult. For instance, helping someone bathe if there's no walk-in shower can be really difficult. Housing that is affordable is another important piece of the puzzle that we focus on a lot. Being unaffordably housed often means poor quality housing that creates safety hazards or respiratory issues for older people. It can also mean that so much income is spent on housing that people cut back on out-of-pocket healthcare costs like prescription medicines. We just finished a study of that. Or food. So again, home-based services can help address things like food access, but affordable, stable housing can address that as well in a different way, by leaving you enough money left over in the month to pay for your food. But I will focus here on the home and community-based services aspect. And just to define home and community-based services, because I think the Centers for Medicare and Medicaid have a specific list of home and community-based services that are provided through Medicaid waivers at the state level. But we also have, I think, a more general conception of home and community-based services. So this is a list of possibilities. There are more than this, certainly. Home and community-based services can be, of course, provided by a family member. The personal care is most often provided by a family member. They can be purchased privately. Sometimes they're covered by private insurance, like long-term care insurance, or they're provided by other state sources, nonprofits, and local governments, in addition to those Medicaid waivers. But the goal is to help people live in their own homes rather than in a higher level of care, like assisted living or nursing care. And for the individual, this generally means more independence, the ability to live in a familiar home or neighborhood, and a tailored set of services that meet your needs and your preferences. Of course, the reason policymakers consider home and community-based services that privately procuring them is very expensive. There's an estimate that 70% of people over age 65 will need some type of long-term care during their lifetimes, which would require, on this chart, a home health aide or the residential options of assisted living or nursing care. Care costs are unpredictable for individuals, but on a population level, other studies have given us a sense of how much this will cost. One recent study estimated the out-of-pocket costs for those needing long-term care services in older age is $73,000. So generally, health insurance doesn't cover these things. Relatively few folks have long-term care insurance. We know that Medicare is limited and Medicaid waivers are limited. So these are the annual costs in Delaware in 2020. Like many, I think, East Coast states, it's higher than the national average. And you can calculate, the homemaker services, that's based on a 20-hour per week service, but you can certainly put in 40 hours a week and see that number double. So one more way to put these into perspective is that the national median net wealth for a renter age 65 and over is under $6,000. So to pay for the services I listed before on a home health aide, for instance, or a homemaker who comes in 20 hours a week, they would exhaust all savings and pay for just that 1 month of care, but just within a month. Owners' median income, and most older adults are homeowners, is considerably higher than that of older renters, but can still be very constrained, especially among lower income owners who have most of their assets tied up in their homes. They have a much lower share of non-housing wealth. And a growing number of older adults have mortgages, which take up much of their income, leaving little left over for services to stay in the home. So for these older owners, staying in one's home can require removing the equity from one's home to pay for services or home modifications. And one more context setting slide. Another issue, of course, that we care a lot about is loneliness, and that can be experienced by anyone of any income. But long before the current pandemic, loneliness itself was often referred to as an epidemic. Loneliness and isolation are distinct but related concepts. Loneliness is more subjective and social isolation is more a state of having limited social ties. But both independently have been shown to have effects on health and mortality. A widely cited study finds that loneliness is more dangerous to one's health than smoking 15 cigarettes a day. And older adults who are lonely are more likely to experience decline in activities of daily living, decline in mobility, and increased risk of death, as well as poor cognitive performance than people who are not lonely. Ooh, I'm sorry about that. Let me just go back. And a possible mechanism is that people who are isolated or lonely often engage in poor health behaviors, smoking more, sleeping less, and getting less physical activity, which I think helps inform the kinds of services that work. So I'll turn now to some examples of programs that address needs for supports and services and social engagement. And this is a bit of a very high level sampler, and I imagine that many of the people in the working group have heard of these programs and more. I can't really do them justice in a slide, but I've provided links that will hopefully lead you to more information and spur discussion. So of course, at the national level, there are definitely programs administered through CMS, HUD, the National Coalition on Aging, and AAAs through the Older American Act funding. So I think it's important to recognize that these models exist. The PACE program combines many services into a comprehensive program. Most of the participants are duly eligible for Medicare and Medicaid, adult daycare, dentistry, home care, hospital care, transportation, all provided through an interdisciplinary provider team. And as of 2020, there were 130 service areas in which programs operate in the United States. The Money Follows the Person program is still a demonstration program, but the goal is to increase the use of home and community-based services, helping people transition out of long-term stays in nursing homes back into the community. And sometimes that can require setting up a new home, putting a new security deposit down, renting that new apartment. And so that program helps with that. iWish is a randomized control trial that has placed resident wellness directors and wellness nurses in HUD-assisted properties to serve older adults. And it helps people develop a healthy aging plan and meet the needs that they set out for them. This is a 3-year demonstration program, and it is in 7 different states right now. And then I'd be remiss if I didn't mention area agencies on aging, funded partially through the Older Americans Act, that provides so many of the services that we know about: Meals on Wheels, caregiver support, help with household tasks, volunteering, advice giving, and then a lot of caregiver support as well. I put one more up on the slide. It's a kind of a different kind of program, the National Coalition on Aging. aging mastery program. It's actually a classroom experience through which older adults increase social connection, physical activity, and healthy eating. And studies have shown results in improved mental health, physical activity, and advanced care planning. And the elder services, the sort of screenshot on the right, that's just one of the family caregiver support programs available through one of the programs that you can access through the AAAs. So I'm going to talk at the more, I guess, local level about services delivered in age-restricted affordable housing before I move to services delivered more widely in the community. And these are photos of age-restricted service enriched housing. These are photos from Massachusetts, developed by Two Life Communities, which is one of the most innovative organizations in this space. Housing like this is built with a host of federal, state, and even local subsidies. It's distinct from nursing care and assisted living, but is really filling in along that spectrum, providing more supports to people who are living independently. And research has shown that people living in this type of housing tend to delay or avoid moves to nursing homes. And the key thing about service enriched housing is the services. Some of the models are owned by nonprofit organizations that provide meals, transportation, a doctor on site, 24-hour staffing, classes, transportation, all that. But even those that don't often have a service coordinator on site who assists residents in coordinating care and services and can help address social isolation. During the pandemic, service coordinators were really instrumental. We actually did a survey of service coordinators working around the country about their pandemic experience and how they helped older adults get food, use technology, keep people engaged even though social distancing was enforced, navigating benefits, translating information from the government. And more research is emerging about the benefits of service coordinators in general. So many of these are employed in the building. HUD grants fund many of them. We're also finding, and this is something I frankly don't know enough about, but is I think a really interesting avenue, insurance providers are offering service coordination to individual members, which often means that you have multiple service coordinators working in a single building with older adults. And I know that in Massachusetts, the Executive Office of Elder Affairs is very interested in whether there are ways to coordinate this work in ways that can be more efficient and allow someone to really get to know that location and the people in the building and be more place-based. So that's kind of an interesting twist on it. A great example of service coordination at work is at St. Mary Housing Development, which is based in Ohio and has 4,500 units of affordable housing in 65 locations, most of it for older adults. And their service coordinators engage in the tasks listed here. And I just think what's interesting and important to note is that the organization really emphasized that the housing and the service coordination are tightly linked, that you can't have one without the other. Service coordination isn't an add-on, but an integral part of the model, and is for the people who live there a way that they are getting these services delivered in their home. Another example that is well known and has wider reach is Sash, Sports and Services at Home, a program in the state of Vermont that provides care coordination and a wellness nurse to participants. They work with a very broad network of providers and partners, including housing providers, hospitals, AAAs, home health agencies, and others. And they serve people living in affordable housing, age-restricted kind of affordable housing, as well as people living in their own homes dispersed in the community. The program is funded partially by the Centers for Medicare and Medicaid through Vermont's Accountable Care Organization, but it also receives support from over 15 state and charitable organizations. It's been a really well evaluated program and been shown through various studies to lower Medicare and Medicaid costs to participants. One study showed Medicaid costs about $400 less per beneficiary per year than at among other older adults in non-SASH locations. Medicare costs went down too because people had fewer emergency room visits, hospital stays, and use of specialists. So this is more of a preventative idea that similar to the service coordinator, that by providing these services in the home, you can avoid providing more intensive services either in the home or in another location. And the model is being replicated or is at least inspiring similar programs in a number of other states, including Rhode Island and Minnesota. And there are some earlier stages of development in still more states. And this expansion has been supported by HUD. A few years ago, awarded $15 million to 40 affordable senior housing developments in 7 states to sort of pilot trials based on this program. Another direction, sort of taking a turn here, is to offer wellness support in the home, while also making the home safer and more suitable for low-income adults. So Capable, which was started at Johns Hopkins School of Nursing, is a program that provides 5 months of in-home support by an occupational therapist, a registered nurse, and a handy worker. The interdisciplinary team visits an older person who is living in their home and who has some challenges living in their home in order to understand their needs and their goals. It may be to be able to leave their bedroom during the day and use their own kitchen, go down the stairs, that kind of thing. And together they work on a plan, and the handy person will repair the stairs or install a banister, and the occupational therapist and the nurse will provide the support to help people improve their mobility and get to be able to use their house. And they've had some really wonderful success stories that you can read about on their website. It's also been extensively studied, and research has shown that there's more than a 6-time return on the investment in the form of reduced inpatient and outpatient medical expenditures. They've also seen fewer difficulties with activities of daily living, symptoms of depression, greater ability to manage medication and do shopping. Capable received initial funding from NIH and CMS. Today, there are over 40 sites in numerous states, and even a program in Australia inspired by Capable. They're all operated a bit differently, some through an accountable care organization, a PACE program, a Meals on Wheels agency, a Medicaid waiver, private philanthropy. So it's being tailored as it's being expanded. Another high impact but relatively low cost program focused on wellness and safety in the home is Comfortably Home, which originated with the Bath, Maine Housing Authority, which noticed that it had a very long waiting list for public housing units by older adults who really needed accessibility. And that was their motivation for trying to get into public housing. And so what they have done is go out into people's homes in the community with a cost of about $2,000 per household, helping to renovate those homes, performing safety checks, making accessibility modifications, minor repairs, really the same kinds of things I think that Capable does in terms of helping people meet their goals for living in their home, but also really focusing on safety. What interests me about this program and about the Capable program is that you don't have to have a documented disability to participate. It can be very preventative. It can help you address a concern that you already have, like the ability to use your stairs. But in terms of something like Comfortably Home, making your home more sufficient or suitable for you as you age can help prevent falls. And there are a lot of home modification programs out there that are wonderful at the state and local level, but often you need a documented disability. So I think that this is sort of an interesting model in that it can help prevent those falls and accidents. And funding for Comfortably Home comes from the Maine State Housing Authority and from philanthropy. Another approach is via age-friendly efforts. And age-friendly communities are a worldwide movement sponsored by the World Health Organization. And in the US, there is support in becoming an age-friendly community through AARP. And age-friendly efforts try to ensure that all aspects of a place are livable for older adults and their caregivers. The 8-petaled flower, one version of it is here, is a standard way of depicting all the elements of age-friendliness, and services are certainly part of this. And these can include memory cafes, respite care, adult daycare, you name it, the services sort of delivered in the community. There are 573 age-friendly communities in the US when I last checked AARP's website this morning. I don't believe at the moment there are any in Delaware, but perhaps there are some in the works. I know it takes a while to get these off the ground. But I think one of the benefits of them, and you can see New York's, this is an image of some of New York's age-friendly effort, which is coordinated by the city and the New York Academy of Medicine. The last time I checked this, they had over 90 initiatives to engage and support older adults. And all of these really have a great reliance on partnerships. One of my favorite stories from the New York program is that they partnered with the Doorman's Union in New York City, training those folks to look out for their older residents in buildings and notice when they haven't seen them in the lobby for a while, or notice if they seem to need assistance. And so just really making these connections and partnerships is a big part of it. States can also earn age-friendly status through AARP or the World Health Organization. And so far there are 8 age-friendly states. Massachusetts is one of them. This is the goals of that. And you might ask, what does this mean in practice? And so I think an important part of this is that the state has taken an active role in identifying best practices and promoting these throughout the Commonwealth through education, sharing with municipalities, starting these networks that meet regularly, engaging state agencies in the business community. During COVID, the state has mobilized and informed many partners in aging through regular webinars and conference calls. And because this network was set up, they were able to do that relatively easily. The work of building a network of age-friendly organizations and becoming an age-friendly state, I think took Massachusetts a decade. But those relationships have really paid off. And so now, for instance, the Mass Department of Transportation in the summer of 2020 launched a shared streets and spaces initiative. And they have included age and dementia friendly practices as a priority for grant awards, which is it's sort of been baked in that that the older population is one to be taken account of and to plan for. And so much of this work is relationship building and elevating of issues, but allowing these partnerships that help people work more effectively and efficiently, and supporting this larger infrastructure that's really thinking about older adults' well-being. A very different approach is one that I'm taking examples here in part from international, from Germany. The photos on the left and the top 3 are of communities in Berlin, Germany, intentional multi-generational communities where there is public support at the municipal, the state, and the federal level for creating these private groups that come together. They're not related necessarily, but they want to live together in a community where they each have their own apartment, but they have a lot of mutual support. They have shared meals, they have shared public spaces, and it's mostly informal, but mutual support. And the idea is, again, that people can stay there longer and live more independently because they are engaged in a community. They have a social life and they have people looking out for them. And if older people do need more care or services that their community can't provide, these can often be brought into the housing. I should add, it helps that Germany has long-term care insurance for everyone, but I think that there's definitely interest in what we can do here. And a slightly different model is the nonprofit or government provided housing for particular populations, sort of intentional communities, but provided by a foundation or a nonprofit or a government entity. So the picture on the lower right is of Tree House, a community in Eastern Massachusetts for families who are adopting children out of the state foster care system. And older residents also live on site in their own units, but they're all participating and expected to participate in the raising of those kids. So the older adults support the parents and they support the kids, they tutor or they coach as they're able. And everyone together is able to access a variety of services and participate in the community. And there are also examples of housing for grandparents who are raising their grandchildren when the middle generation is not present. Such housing offers supports like help with homework and support for the grandparents. And again, the idea is engagement and support where people live rather than needing more intensive services. Another way this can work is through house sharing. And I'm kind of going now into a private model, but these have been working with city governments to promote house sharing between older people and other older people, or older people and younger, like grad students, which is the Nesterly model. And that was started in Boston. It's in more places now, but they have been working with the city of Boston to help match older people who have extra space in their homes with young people who come to Boston to go to school and can't find affordable housing. There's a social aspect. There's also the idea that the younger person might be able to help shovel the snow or take out the trash. And so there's sort of mutual help and social aspects to these. And Silver Nest is also another private company, but it's working with city housing agencies to help promote this. And so I think this may not seem like service delivery in the home, but it is a way of providing support in the home that can, reduce the need for external services. And NORCs and villages are yet another vehicle through which these services can be delivered. So NORC, naturally occurring retirement communities, are generally places where the majority of the population is over a certain age, whether that's 55 or 65, depends on your measure. It was not planned that way. It's not a retirement community. It is simply a place where people have aged in place and grown older together, or the younger people have left, or they have all perhaps moved to a retirement area, but not a specific community. And in Penn South in New York City, this very, very large building, cooperative building, many of the older residents had aged in place, and they developed a social service program for the residents in that building. So these can be provided by a building, by a community, and NORC can be a whole neighborhood, and usually funded by government agencies and philanthropic organizations. So the photo here is of East Point, a NORC in the Atlanta suburbs, which offers supportive services to neighborhoods that has a high concentration of seniors. And again, it's transportation access, health and wellness, home repairs, education, relies heavily on volunteers. They do not have a stable public funding source, although sometimes they do get that. But I think that also sort of brings up the point of the stability of funding. And villages are a slightly different model. They're typically membership organizations, first started in Beacon Hill in Boston by people who wanted to remain in their homes, but were struggling, and they sort of banded together to form an organization that provides referrals to verified contractors for work in the home, transportation, social opportunities, sort of taking advantage of the proximity to create efficient service delivery for themselves. So I'm just going to wrap up here. There are some lessons I think that we can draw, and the pandemic certainly has shined a bright light on the strengths and weaknesses of some of these things. We're engaged right now in a project we're calling COVID Recap, which is trying to elevate lessons from the pandemic about housing in the community or dwelling in the community for older adults. And a lot of that will relate to services. So I think these lessons apply to normal times, but also to challenging times. So I think most of the programs that I've shared rely heavily on partnerships between housing and health providers and the coordination of health and housing policy. This is certainly true of the formal programs like Sash, which has dozens of formal partnerships to help it function across Vermont. And I know that this requires a lot of work and effort, but builds an infrastructure across organizations that can adapt when needs change, as they did in the past year. But another lesson we're learning is that informal relationships and partnerships are also important. And during the pandemic, for instance, when service coordinators suddenly had to pivot, their residents really couldn't come out of their apartments. They were having difficulty getting to the doctor or getting medicine. Those service coordinators were able to partner with other community groups, with restaurants to bring food to the building, to get donations of tablets so older adults could get online. Robin Lipson, who's the Deputy Secretary of Elder Affairs in Massachusetts, says that an emergency is not the best time to develop these partnerships. It is better to do it in times when we are not in a pandemic, but getting to know the health department, the pharmacist next door, the clinic around the corner, the agencies that deal with transportation often lead to really valuable partnerships in normal times to help with service delivery. And then again, in emergencies can really help people pivot to provide support. And on a higher level, I think we've learned that partnerships and relationships matter in a different way. Just that idea that being an age-friendly state in Massachusetts had already established many communication channels to stakeholders that allowed them to share best practices during the COVID pivot. And to put things into people's minds, like the transportation providers recognized the need right away for specific transportation to help older adults get to vaccine locations. So there was a real value in having that. Another lesson, and this also comes from Robin, is that there's a great importance of trust. Many older adults may not trust government providers, or they may not be able to access information in their language. And Robin stressed the importance of working with local influencers in the community, understanding cultural barriers. And she was talking again in the context of rolling out vaccines, but I think you could apply those lessons more broadly to making home and community-based services work. You need allies in the community and you need trust with the provider. And the stability of funding is also a big issue. Obviously, I think that sort of goes unsaid. Many of these organizations rely on grants that are renew it or not year to year. Another challenge is that for especially for housing providers, the eligibility that gets you in the door, your income eligibility for HUD supported housing, may be very different from the eligibility that you have for a home and community-based service, either through a Medicaid waiver or through your state's programs. And so that is a real challenge for those providers who are already in this day and age, dealing with multiple funding sources for their housing side, and then again, dealing with this sort of mismatch on the health side. And then lastly, of course, there are workforce challenges for home health aides, for nursing home workers, for the people who provide the support. The professionals' pay is low, work can be physically demanding. Lifting people, for instance, often has resulted in injuries. So I think one focus is on improving working conditions for that class of professionals. This picture here is of a home in Singapore that provides housing to older adults, but a very big daycare and childcare center for children. And one of the things I've heard percolating here in the US is, what if you provided childcare on site for the workers in the nursing home? You provide for multi-generational opportunities, and you're sort of doing a couple things at once. So this isn't exactly the same, but I kind of thought this model was inspiring as well. Two very quick lessons. Virtual service delivery can be really amazing. I think we've all learned that, and we're all in a webinar together here from different states, and that's all working well. But we have to be aware of the digital divide, especially as it relates to older people, not just in access to the internet, but actually owning a tablet or a laptop and then being able to use it. And then lastly, I think outreach is something super important. People often don't know where to turn when they need help for themselves or loved ones. And I'm sure that some of the other members of this working group can attest to this. They may not know that some great benefits and programs exist, or how even to begin to access them. And this is a portal that the National Council on Aging puts out, where you can type in your zip code and get information on what, in your income, and you get information on what you might be eligible for. So being mindful of the digital divide, I think we really need to think about this part, particularly outreach to rural and traditionally underserved communities, and those that may not have a natural trust of outside entities providing help. So these are some resources I will leave with Will, and hopefully will be of use, and invite you to come to our website too for some information on the national scene. Thank you.
Thank you so much. That was it was very interesting to see the different initiatives from across the country, and I just gonna start off with a couple questions. The slide that you showed regarding the multi-generational households. Tell me more about that, because I think that's a very important part. A trend that we're facing, and I guess this is even regardless of the pandemic. The trend towards multi-generational households. Is that correct?
Absolutely. And as I said, I think there are traditions of family caregiving and support in some cultures, and I think that's part of it. I also think that economics plays a role too. Hispanic and Black households have lower incomes, and so there may be something about that, about affording housing too. But certainly then you get into the question of the physical house and what kind of house can accommodate a large multi-generational family without overcrowding and all that. And that certainly came up during the pandemic. Multi-generational households had built-in support networks, but also people faced risk from infection of COVID because some people were outside in the world and older adults were in the home.
Mm-hmm. And when you look at some of the other examples, I mean, like sort of like the service enriched housing and that you talked about, or where does the funding come from for that? I just want to make sure I understood. How are things like that funded?
So there can be so the model I showed you is a nonprofit that gets funding for its housing from Section 202, housing for the elderly. from HUD. They may get some voucher money. They get state monies. In Massachusetts, for instance, we have a surcharge at the local level that can be spent on housing, historic preservation, and recreation. And so they access that housing money, low-income housing tax credits. One of the things that I understand, and I'm not an affordable housing developer, is just how complicated this package is to put together, and the sort of legal and administrative costs of putting all this together, because there's no one single source like it used to be. I guess that you could really get most of your money from Section 202, and now it's a bit more challenging to pull that package together. But that's how they do it, and then they might get a service coordinator grant through HUD, or they might fundraise for that. I think that 2 Life fundraises for theirs. So there's, I think it's a fairly complex endeavor to sort of pull this all together.
And my last question for now is like, I get the partnership, the concept, and how important partnerships are needed in putting all this together. Who drives sort of kind of pulling these partnerships together? I mean, are they coming from the state? Are they coming from local governments? Are they coming from nonprofits? Are they coming from community groups? What is really spearheading, the drive to put these partnerships together, to put these programs out there?
I think it depends on the initiative. I think a lot of the age-friendly is bubbling up from the local level, work on the ground at the very local level, trying to coordinate within one's community, reaching up to the state. But then, I don't actually know how Sash got started, but it's so statewide that I think right now, it probably has a lot of support from higher up.
Okay, let me open up for questions from members of the working group. Questions?
Jennifer, I had a quick question for you. I used to live in New York, actually in Queens, and there's a lot of the naturally retiring communities out there. It's a fabulous setup. And one of the questions that I had was in terms of the transportation. How do they typically get involved? Because being in New York, everything's accessible, and there's a bus every 5 minutes. So how does the transportation group sort of come into this?
Yeah, I think that many communities, and New York is an exception because its transportation system is so robust, but many communities offer transit, but it may not be really well suited to older adults. Even if it's accessible, it may not go where older adults want to go. It's a rush hour kind of schedule. If you've noticed, really broken down bus shelters or broken sidewalks on the way to the bus stop. So that's where a lot of the action comes in helping to understand the whole network. It's not just having the bus, it's getting from your apartment to the bus. And so really engaging transportation around that. And then I think the other big thing is paratransit, because some people will not be able to use a bus or a subway. So really engaging around specific paratransit operations.
Just thinking in terms of accessibility, that's the biggest thing. You can have all of these amazing components out there, but if there's no way for them to get from point A to point B, how do you make that happen? So I was just curious, do you know if there's any, just as a follow-up question, are there any other subgroups, maybe not through a city transportation or state transportation, but like an Uber of sorts that maybe they use for those individuals that can't use that type of transportation, just out of curiosity?
Yeah, I'm sure that exists, and I don't know specifically about New York or any other, but each of these is, each of these age-friendly communities has its own flavor. If the Atlanta Regional Commission is another one that's often touted for its age-friendly efforts, and a lot of that is focused around transportation. It's a much more spread out area. It has a different focus. New York's focus is, I would say, more public health oriented. Massachusetts, I think, has a more explicit equity of access to housing. So, they all have their own focus, I would say, even as they pull from all the petals of the flower, as it were.
Thank you.
Any other questions? All right.
Jennifer, may I, Senator? Thank you.
Sure.
Jennifer, thank you so much for the presentation. It's exciting to hear from a healthcare perspective that these models are helping reduce, spend on healthcare and the prevention in the long run. workforce is of particular interest for everybody right now. But coming from a home care perspective or anything in healthcare, what would you say, maybe a multi-part question, are you seeing the successes of the coordinators filling that gap? Is it families filling that gap? And, as we look to create these communities and help people age in place, are there any room within this funding streams that you've seen that's going to help bolster workforce in that regard?
Yeah, I may not be the best person to answer that, frankly. I'm not sure I know enough about the connections between workforce and the and these kinds of efforts. And I just had a thought and it went right out of my head, and it'll come back to me. I'm sorry.
I'm sorry, and I asked too many questions all at once. But to see, it seems like those coordinators, I mean, we see that at Westside, we see that, in our own experiences, to have somebody that can be the quarterback to connect people seems really key and important in these communities.
Yes, absolutely. I think more and more evidence is coming out to that effect. And again, the model varies, right, from a service coordinator who is really coordinating services to the wellness nurse model in Sash or in the I Wish program. But all are geared, I think, towards that preventative wellness, that, the preemptive need for services. And then when you have a need for services, connecting you to the right place and making sure everyone's looped in.
Great, thank you.
Great. Any other questions?
I have a quick question. Certainly I'm looking at this slide here around older people of color more likely to live in multi-generational households. But I'm wondering if you have any specific examples of ways that these strategies have assured that they are culturally competent strategies that are being deployed.
Yeah, I don't, but I think that there are lessons to be had in the vaccine rollout, because what I understand from many examples around the country is just how instrumental the party was, either the community development corporation or it's the housing provider, it's the service coordinator in the building, and pairing with local partners, whether it's religious institutions and faith leaders, but really, the basics, making sure the information is translated and accessible and all that, but then really working with trusted people to, in the vaccines case, convey the importance of it, but also, get people to the locations. But so I would say that that's the biggest thing that I'm learning from the pandemic experience, is just that person on the ground that you can partner with.
Great, thank you.
I'm just going to kind of, I thought Katie was going to ask a different question, but I'll ask it then. But what about memory care? I mean, I think, we're really, when you start looking at, the issues, at least I've heard in talking to folks, challenges, we start looking at, either Alzheimer's or other forms of dementia, and as opposed to physical challenges. Does that play, how does that kind of work into some of the things you've seen in these programs or some other places?
I think it does. I think in the age-friendly, and I know a lot about Massachusetts and Boston, so I keep using these examples, but there's a great focus on memory care, on memory cafes. They all went virtual during the pandemic. I think, and on caregiver respite and support in that community. So I think that those things are happening. I'm not sure about programs, and I'm sure they exist, I just don't know about them, that are really facilitating a person with cognitive issues remaining in their home long-term. I mean, I can, Katie, maybe you could speak more to that than I could, but yeah.
Yeah, I mean, I think what you just said, ensuring that respite services are available, caregiver support, that's all incredibly important. But I was also thinking, you're talking about, what would they call that? Healthy aging plans, incorporating just cognitive health into those overall healthy aging plans, helping folks manage comorbid conditions. For example, we know that about 95% of people with dementia have one or more other chronic conditions. So they may also be managing diabetes. So being able to manage those other chronic conditions can help that person to be able to stay at home longer and help their families manage those other conditions. So thinking about healthy aging, but also risk reduction, brain health that may reduce one's risk for developing dementia and allow them to be able to stay in their home or community of choice longer.
Yeah, thank you for that. I mean, I think the loneliness issue goes to that too, of engaging people so that that can be headed off a bit. Yeah.
Yeah, I mean, certainly social engagement is a key component to a brain healthy lifestyle. So yeah, absolutely.
Great. Thank you very much. I think we should be able to get a copy of those slides.
Absolutely.
Yeah, I mean, and we'll share that with the working group, and that'll be part of the documents that are available. And again, since this meeting is being recorded, people can watch it again. But I really do want to thank you for your time and for a very, very informative presentation. So we may be calling on you again.
Thank you. Anytime.
Thank you so much. Now I'd like to move on to advancing states with Martha and Adam. And then Melissa will be offering some points as well in this as well. So I'm just going to hand it over to you and take it away.
Thank you. I think we're actually going to start with Melissa. Is that right? Okay.
Sure. Well, thank you for the opportunity to share our thoughts and ideas about improving the state delivered services for Delawareans, especially as it relates through the Division of Services for Aging and Adults with Physical Disabilities. So I'm going to take the first couple of slides just to lay the landscape and some reasoning behind why we saw a need for change, and then some goals that helped drive our partnership with Advancing States and looking at some options for improvement for Delaware. Yep, thank you. So some symptoms of a reason to change are, number one is a long and unrelenting wait list for services through our division. We've operated with a wait list for a number of years and seen some success in reducing the wait time on the wait list through some generous funding through the state legislature. So people are getting on services, they're waiting less, but they're still waiting. And so we see this as a problem that's perhaps more systemic than just funding based. We need to continue to improve our Aging and Disability Resource Center and continue to build on the ADRC as a no wrong door access point and continue to offer additional opportunities for access and linkages to benefits and services that are outside of our agency, in addition to the services that we provide. We want to spend more time and effort focusing on those social determinants of health and those healthy aging components that keep individuals in the community and support aging in place. And so we would like to see less of our overall resources being kind of on the far end of more medically based services and start to spend a little more time on disease management, nutrition, mobility, and we're looking to shift so that we can have a more equitable balance of where we spend our money and our resources. And then finally, there are just some operational efficiencies that we need to attain in the way we individuals access our services. Right now, it's a little uneven in that some resources are and services are accessed by going through the ADRC. Most are, but a couple of key services, including meals and adult day, there's a separate assessment process. And so we're looking as we go through this reset process to consolidate everything through one assessment process in an effort to be more person-centered. So that gets us to our goals for change. And I saw the little circle spinning, so there we go. Number one goal is to serve more Delawareans. We saw in our last meeting that Delaware is going to enjoy a very robust aging population. And so we need to figure out a way to continue to serve more and more Delawareans. We think and know that this is possible through a more efficient leveraging of Medicaid dollars, and also believe this will help address the wait list as we assist more Delawareans that are eligible for Medicaid to access that robust service package and allow Older Americans Act dollars to go towards those individuals that really have no other options for benefits or services. We want to support, better support family caregivers. And fortunately, this is a priority shared by so many in the state. So we feel like we're at the right time and the right place to look for opportunities within our system to join with everyone else that's looking to increase the supports given to family caregivers. As I mentioned, we really want to support healthy aging in Delaware and really embrace aging as a vibrant and healthy aspect of a natural lifespan. And so give Delawareans the tools that they need to live the most healthy and self-directed life that they can in the community of their choice. And all of this comes from a perspective of person-centered care. We're looking to continue to build and strengthen our system of care to be person-centered, to focus on the goals and desires and wishes of the individual and where they want their services and how they want them delivered. So I think the final slide that I'll be talking about today, it's a little dense because it has all of our community programs on here. And so I'll take the opportunity here to quickly just note that the Older Americans Act is the enabling legislative language that creates our state unit on aging and all of the state units on aging around the country, and also prescribes some of the services, supports, and roles of our division. This slide here shows all of our community programs, not all, most of the most popular. And in that green box, we highlight those services that we provide as well as Medicaid. And this is this key area where we're looking to really maximize efficiencies and better leverage all dollars that are available in Delaware, from the general funds to Older Americans Act to Medicaid funds, to really most efficiently serve as many Delawareans as we can. So at this point, I'll transition to our Advancing States team to pick up. We saw all of this and asked them to come in and help us think through how we might meet our goals and also leverage the experiences of other states and best practices. So Advancing States, I'll hand it over to you guys.
Thanks, Melissa. I'm Martha Rorty. I'm the Executive Director of Advancing States, and I really appreciate being here today, and especially that the senator said my name correctly, because it is true that my family name Rorty is a spelling error at Ellis Island, and everybody with that spelling name is related. But it's tricky. It's like Doherty, but most people can't figure that out. Anyway. Advancing States is the national association that represents state aging and disability agencies across the nation. So it's all the states that administer the Older Americans Act programs, as well as the long-term services and supports Medicaid programs. So it's a broad continuum of members. And we focus really on 6 key areas. It's home and community-based services, primarily focusing on those in the community, although obviously the continuum of care is nursing facility care as well. We really, our members are really encouraging health and wellness and aging well in the communities, supporting consumer access, and to Chris's point, being a great quarterback for individuals as they're going through the system. This actually is one of the key areas of focus for us, and very much when we're doing stakeholder engagement, one of the areas of trauma almost is trying to access the services that people need and then continue in through the program. We encourage states to measure the quality of their services. We, in partnership with the Human Services Research Institute, administer a consumer satisfaction tool that Delaware does participate in, which allows you to see the satisfaction that people have of their services over time. And in different departments, you can compare and contrast how it's working. Preventing exploitation is really looking at programs like the Ombudsman Program, Long-Term Care Ombudsman, and Adult Protective Services Program to make sure that those most vulnerable in our LTSS system are not being harmed. And then really working with community-based providers that are the backbone of our system to encourage better business acumen so that they can sustain themselves. In addition to doing all this as a member service, we also provide more enhanced technical assistance to states that want to go deep into some of these areas. We can provide the 50-state analysis, and we do all the time, and share promising practices with with the focus on these 6 areas. But some states have hired us to go deeper into redesigning their long-term services and supports, and Delaware is one of those systems, or one of those states. We're also currently in Indiana, Kentucky, Rhode Island, Pennsylvania, Maine, and Minnesota. And obviously, I think one of the great benefits of that is there's learnings that we're learning from all the states that we can share with the real in-depth knowledge that we're getting from some of the other states. Next slide. So over the last 2 years, we've been working with Melissa and Dava before that to kind of look at ideas for recommending improvements for services for older Delawareans. We did get a little bit of a pause in our work because of COVID, and we focus more on helping the state through COVID. But then on the other side, we've come through with some recommendations. We've done the recommendations based on the promising practices that we have from other states, as well as learn from other states, as well as we have done stakeholder engagement, where we interviewed individuals across the state, and we interviewed the staff to determine what areas they thought were ripe for improvement. Next slide. So the first is to really support the pre-Medicaid population, those that are not obviously in the Medicaid program yet, but that need some supports and services in order for them to age in place. When we first got to visit with the DSAPD staff, I remember thinking and driving back with my colleague Camille, who's actually vacationing in Delaware today. She's not here today, but she's there. In any event, we both were struck by the fact that the programs and services that were being offered mirror the Medicaid program. It was like what happened was when the Medicaid waiver moved out of DSAPD, they never re-examined what they were offering to see if it made sense in the same way. So one of the things that we want to do is make sure that the service array package is focused on those adults that need it the most in order to stay in their home as long as possible. We believe, based on our preliminary analysis also, that at least 30% of those that are receiving the personal care services right now are really Medicaid eligible. And we want to encourage those individuals to go into the Medicaid program to receive the full array of services that they could if they were in the Medicaid program. And then there's another 35% based on our analysis of the individuals that are receiving personal care right now from DSAPD that could pay some sliding scale cost share for the services that they're receiving. And the state's hoping to do this in order to reduce the wait list. This is such a valuable service. We want to make sure that more people that need the service can receive the service, and that we also want to ensure that those that are eligible for Medicaid migrate into the Medicaid program. We really think that this will allow the state to serve more people this very valuable service. The next slide. Our next recommendation is really around person-centered planning recommendations. So there's a couple of things here. The first is that the current assessment tool that is being used is not nationally recognized as an assessment tool. It's kind of a homegrown model, which leaves the state open to challenges in the court by individuals that say, why did I get this and she got this? And I always liken it to when I do staff evaluations at the end of the year. I love everybody on my team. They're all awesome. And so I always give all A's. And then my partner, Camille, is not as generous. She gives not all A's. And so we have to come together and make sure that it's a little bit more fair the way that we're doing this. A nationally validated tool wouldn't be like that. It would be agnostic to who's giving it because it's been tried and true over and over again, so that the individuals that are getting the assessment, or I'm sorry, doing the assessment can't rig the system. It's the way the questions are worded, the number of questions, and the order that the questions are done, and provides for some validation there. So that's one of the recommendations that we have. We also want to make sure that we're simplifying it by bringing all of the assessment processes in-house. Currently, in order to receive services, the services have to be, if you want meals, you go one place. If you want adult day, you go another place. And then if you want everything else, you go into the DSAPIT system at the Aging and Disability Resource Center, which means that people that really probably need additional services, people that are eligible for meals, likely need another service and aren't able to receive it in a timely fashion as possible, or they have to go through a whole nother assessment process. As somebody who served as a family caregiver for an adult, or my late husband with Alzheimer's and an adult son with autism, I can tell you that doing multiple assessments that last at least an hour each time is not what I want to do when I'm being asked the same questions over and over again. So we're trying to simplify it for the consumer and make sure that they do have at the state a quarterback that is helping them to be connected to all the services that they would need at the same time. And we really think that will also help to ensure that we eliminate the conflicts of interest that are inherent in a system where a provider potentially is the one doing the assessment. And no disrespect, but the chance of them saying yes, they're eligible is higher because they would get paid for that. And so most of the instances, we haven't found a single other state that allows for providers to do the assessment and then provide the service at the same time because of the conflict. Sorry, I'm losing my voice today. Next slide. I think I'm turning it over to Adam for the next one.
Absolutely. Thanks, Martha. Good afternoon. Thanks for letting us speak to you all today. Senator Mantavinos, as well as Representative Griffith, it's good to see you again. I know we had the opportunity to speak a couple of weeks ago. So just hammering home on improving access to services. So Melissa alluded to this in her opening remarks as well, but there's really some potential to build out the capacity of Delaware's Aging and Disability Resource Center, or ADRC, to really improve the system to not, currently as it stands, the ADRC acts very efficiently and effectively as really an intake system to connect consumers to DSAPID's community services program, and really acts as an intake system, takes the consumer and connects them to this community services program. And I think in some of the earlier discussion, this came up, but really what the ADRC should be doing, it may appropriately serve as that intake system, but it may also should be serving as that quarterback for that individual. So when they come in, they're being assessed, and then they're exploring the full continuum of resources that may be available to those individuals. So that should be community-based resources. If the person has the resources to pay, they should be exploring private pay options. They may be looking at sister agencies in terms of, are they eligible for Medicaid? So really building out the functionality of the ADRC, also improving the support of the ADRC, not only for older adults, but also individuals with disabilities. And so that's what really the recommendation here, developing a more robust no wrong door system by building out that capacity of the ADRC that will hopefully allow the ADRC to provide that additional support in terms of developing a no wrong door system, which is really the ideal state for a no wrong door system is a streamlined system of access for consumers to long-term services and supports for all individuals, older adults, individuals with disabilities, excuse me, and their caregivers. And then finally, and just of the utmost importance, this was supporting family caregivers was really identified early on by the DSAPID leadership for us, and really am heartened to hear really, I think the coalescence around this this topic across the state. But we identified early on, in addition to it being identified by DSAPID leadership, that there's some room for potential improvement in Delaware for supporting family caregivers. You may all be familiar, every couple of years, AARP publishes their long-term services and support scorecard, which measures state LTSS performance. Overall, Delaware ranked very well on the scorecard, but actually their lowest score overall was actually in terms of support for family caregivers. They're ranked 31st in the nation. So I think that was also just an illustrative example of some potential opportunities there. We're also aware of some of the ongoing activities across the state related to supporting caregivers. I know the state is engaged with the National Academy for State Health Policy, or NASHP, which is going to be doing some focus groups and collecting information from caregivers themselves, which I think will be immensely insightful into how Delaware continues to explore what opportunities the state wants to move forward with in terms of additional supports for caregivers. States really go at this issue in a number of different areas. A lot of states have been looking into adopting a caregiver assessment. That's something frequently discussed now. Others have put state general fund dollars into respite programs. Frequently, respite is identified as the most sought after services by family caregivers. And so some states have done some state appropriations to help those caregivers caring longer. So those are just a couple of quick examples in terms of different opportunities for the state in terms of supporting family caregivers. And I know we went through those recommendations pretty quickly, but in terms of our formal presentation, that concludes us.
Great. Well, thank you very much. Just real quick, I want to make sure I understand how far along is the staff in implementing, some of the work Advancing States has done so far.
I'll jump in here and say we're right at the transition point from planning to implementation. So we've spent the last nearly 2 years really evaluating planning, and we're now sharing it, the plans, the thoughts, and policy decisions with stakeholders. And next, we'll be taking feedback that we've been receiving throughout the last almost 6 months of collecting stakeholder feedback, and then developing implementation guides for the specificity of these recommendations, and then also staff training. So we'll be moving into the next phase now.
Yeah, finally, this is all good. This is good stuff. So I mean, I think the thing that really jumped out at me, when I first saw this was, again, the overlap with Medicaid. I mean, can you talk a little bit more about that, and what you see in terms of how that's going to, how you're addressing that.
I can speak from Advancing States and from what the other states are trying to do. There's an absolute need for serving low-income, elderly, and people with physical disabilities in the Medicaid program. We all know that. And similarly, the Older Americans Act targets pretty much the same group. It's a low-income group of individuals. Because the funding from the federal government is limited for the Older Americans Act. But where the the sweet spot that you can actually do a lot of good, and it's a long game to do this, but is really to focus on keeping people healthier and living well now, so that they don't need to have the long-term services and supports for as long or at all. if possible. And so looking at programs that support family caregivers so that they don't burn out of doing the caregiving for a loved one with dementia, for instance, or if it's doing more evidence-based health promotion programs and talking to people about brain health and exercise in their 50s, not waiting until they're, in their 70s or 80s when change is harder and change might not have as much of an impact as if they change younger, I think is where the state really wanted to focus and where the trend is really to focus as well, I think. Because I think that everybody has recognized that that's where we can gain the most value in the system, I think. If that helps.
Yeah. Go ahead.
I did want to also jump back to the last presenter. And Maggie asked a question about transit, and I can answer the question too. Sure. Because we're a national association. So one of the ways that states do some unique rides for people, especially in rural areas, not like New York City. And I'm from upstate New York, where it's 45 minutes to a grocery store. So I'm the other side of New York. But one thing that Arizona is doing, which is very rural, as you know, is they partnered with Lyft, and Medicaid and non-Medicaid rides are being provided by Lyft through state dollars. But here's the really cool thing that they also are doing. In order to get enough accessible vans, they're asking people that have an accessible van that may be disabled themselves to become Lyft drivers. And then they reimburse them for giving that ride to somebody. So that's a pretty cool approach to that. And then the other thing that we saw with COVID especially was the amazing partnerships that developed using the handicapped accessible school buses for non-school times, so that you could transport people with those non-school buses for non-school activities using the handicapped accessible buses. It's remarkable how well that actually ended up working.
Any questions from any members of the group?
I had a question for Melissa, just in terms of I know you have a ginormous wait list and there's a lot of people looking for services, and is there other areas of funding that we could be looking at or tapping into on either, whether it's state or federal? I would assume it's probably more federal, but just trying to think in terms of that wait list.
Yeah, well, I appreciate that, because we need to do something about that wait list. I might defer to my my membership organization here. The three pots we're really focused on right now are the general funds, the Older Americans Act dollars, and then leveraging Medicaid dollars. And we really feel like we're going to get a lot more bandwidth by better leveraging those three together. But I'll defer to Martha if you want to add to that.
Yeah, I think that the most impactful way that we can get the wait list down is really to get those that are Medicaid eligible now into the Medicaid program. Because our very, 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 very conservative estimate was that more than a third are eligible for Medicaid. And if they went into the Medicaid program, they would qualify for a lot more than just that. But also, we could take a third of the third of the people that are currently participating and empty those slots for people that could get it. The Older Americans Act it's not going to make a dent in any of this. And I don't think that there's other federal funding that would be supporting the cost sharing for the states that have leveraged it. In other states, Massachusetts has leveraged it. I'm going to try not to rattle them off, because a number of states have done it. And I know that they have found great success with it. People they're not opposed when you ask them to pay for a portion of the service that they're getting. Especially if they really need this, like if they have the money and they need the service, they'd rather have the service delivered than go on a waiting list, if that makes sense.
I had a quick follow-up question then, Martha. 30% is kind of that's a pretty decent sized number. Is it potentially the hesitancy of going to Medicaid? Is there?
I think that there's some myths that we have to dispel. I think that people think what we heard when we did stakeholder engagement was, if I go on Medicaid, I lose my house. And that's not necessarily true. And so I think there's, as part of the implementation strategy, is really going to be an implementation media and public awareness campaign around who and how you become eligible for Medicaid, and what is on the Medicaid program, that, you know, taking away some of the stigmas, I think, from the Medicaid program, I think will also be very helpful.
Thank you.
Do you have a sense of like where the population is for that 30%? I mean, is it kind of equally distributed statewide? Is it concentrated in any particular area, or is that something that's you really can't determine?
Melissa, we didn't look at it by zip code.
We didn't, but we do have, I won't speak, you know, in terms of numbers, but we see all Delawareans. So we serve affluent Delawareans right now. And then the larger proportion, of course, are low income Delawareans, but we serve the spectrum.
No, I get that. I was just kind of thinking, again, as we touched on last time, you know, where this is a statewide, you know, issue that we're looking to you know, we're talking about. And if there are, you know, is there a concentration perhaps in one part of the state versus another, or if it's equally distributed? I think that really could have an impact on the conversation. So I'm just kind of curious to that.
It's a good question. Yeah.
Any other questions from the group today?
If I could say one thing, I had a question about the again the 30% Medicaid eligible, which I would think would make a huge difference for some of the other disabled programs. The one thing I felt over time in helping different people through that process, you know, you couldn't go through the whole thing with them, and it is a lengthy process, and understandably, you know, the first you apply financially, then if you might be eligible, you apply for the MLTSS program. So a lot of time passes, and I think people could give up, or they're just a little exhausted by the time they're needing that. So I love the idea of trying to meet these people in their communities before they need it. But I'm also hopeful of a little bit more intense navigation for those that begin to access. I just, you know, you get a series of envelopes, say from Medicaid, following up on your financial application, but you're not feeling well to begin with. So that's piling up on the table, and then you didn't follow up, and you don't know where you put all those papers.
Yeah.
It's just
Jean, I want to share with you that when we met with the Aging and Disability Resource staff, they were very concerned about some of those individuals, that they would help on the front end to start the application, and then realize that maybe they didn't understand some of it, or they didn't submit the paperwork or whatever. And Melissa and her team have some dedicated people that are working with those individuals, specifically the ones that they know are eligible but that are struggling, to maybe explain it in a different way, like what the form is that you really need, or what the, you know, what does adjusted gross income, what is, like, those things sometimes are a little more complicated. And so having somebody to handhold through the no wrong door is, I think, the direction that they really want to go into. I'm stepping on Lisa, I think, has her hand up.
Lisa, go ahead. Yep.
I do, and Senator, thank you. I hope you can hear me now. I think the technical difficulty was resolved. So since the word Medicaid's been used, I don't know, 42 times in the last 10 minutes, I thought it might be beneficial for you to hear from the Medicaid program.
Yeah.
So certainly we are in great partnership with Melissa and her staff in the ADRC around assisting folks through the application process.
And Jean, just a few points of clarification. So it's not like you apply for Medicaid and then apply for LTSS, long-term supports and services. You actually come through the door through our central intake office and raise your hand and say, you know, I need help with services in my home, or I want to go into a nursing home. You know, these are sort of the things I'm struggling with. And then in addition to the ADRC, the Medicaid staff also assists folks through that process step by step. Once they send that application in, they get a social worker assigned to them, and they're with them every step of the way. That process, you know, the federal government gives us 90 days to determine Medicaid eligibility, and in Delaware, we average 45 days statewide. So we're pretty proud of those numbers and feel like we do our very best to process those applications timely and get folks the services that they need immediately. The other piece I want to point out is that when we transitioned to managed long-term care here in the state of Delaware in 2012, one of the things we built in was a bridge for folks who are on Medicaid, but maybe not on long-term care Medicaid yet. But as they begin to need those services, we do have the MCOs help them walk across that bridge and make sure they get to us so the resources can be assessed and the level of care can be determined. So our MCOs also partner to help folks, you know, through that process, along with Melissa's staff and our staff in the offices. So just a couple points of clarification there.
Thank you, Lisa.
That's helpful. Any other questions? Okay, well, thank you very much. Very informative. And I think it's good to understand. It's good things to understand as we're moving forward. So I'm looking at the clock. It's 2:36. We got about half an hour remaining. So I'd like to kind of move on to the next item on the agenda, being sort of a discussion of the subgroup expectations. Everyone should have received a memo from Will that has updated some definitions and the objectives for the subgroups. And I think Will is actually pulling these up. Awesome. Thank you, Will.
Actually, Senator, I don't have the specific expectation. Okay. Yeah.
That's fine. But so everyone should have received this, and it basically incorporated the feedback that we had during our first meeting to sort of tighten up and clarify objectives for the different subgroups. And you should all see which ones. There were some subgroup definitions that were in the presentation that were abbreviated. This memo sort of expounds upon them a little more, as well as notes what was added to the definitions and sort of the objectives during the last meeting. So we can certainly make sure that that is shared. And I think everyone who is, as we're looking to populate the subgroups, will get again these definitions. And again, for those who are participating, who are listening in, we invite people who are interested in participating in this process to participate through the subgroup process. Very quickly, we have subgroups. I'll just read the titles. The social determinants of aging well, racial disparities and health equity. That's the first. Second is 21st century caregiver workforce issues. The third is promoting access to support services and combating isolation. And the fourth is financial and legal barriers to aging in place. So again, everyone who has signed up to participate and listen in to these meetings, we have your email, and I believe we'll keep you on our distribution list to be able to get this information. But we want to make sure that, again, if you have an interest and you're interested in any of these subgroups, that we invite you to sign up. And we have a form that will be sent to those who are participating and watching our meeting. Yes, Will? You're on mute, Will.
Yes, sorry, I couldn't find the unmute thing with the Zoom. Still
problem.
mastering this. That is correct. The form will be sent out. If you haven't received it yet, send me an email, or if it's been lost in the stream of emails, send me an email and I'll send it over for you.
So we will ask everyone again to list the first and second choice. And we'd like, I'd like all members of the working group to participate in at least one subgroup. I know I appreciate everyone's participation in the work group, but we'd like to, because of the depth of this topic, want to have an opportunity to dive down into these areas a little more. So if you can list a first choice and then the second choice, we want to make sure that the work groups are, the subgroups have an equal number of people and the proper expertise in each area. So we'll be looking to form that, which really is going to lead to the next point, which is, we had the first two meetings sort of providing information to the group. And I think now we're ready to try to dive in and start to get a little deeper. So we're probably not going to have another full meeting group, working group meeting until the 29th. I believe that's the date we said, 3 weeks from today rather than 2 weeks. In the interim, we'd like to start these work groups, the subgroups meeting. And like I said, we hope to get them all populated now that the governor has made his appointments. We'll be reaching out to those individuals, make sure they get caught up to speed with the information from the first meeting and today, and we get them involved into those subgroups. So again, the expectation at this point is, again, working, you'll be hearing from Will. We'll be looking to convene these different subgroups over the next, I would say next couple of weeks, so that we can at least get that process rolling. And so by the time, again, we convene the entire group in 3 weeks, we can start to have some reports or some initial thoughts that are starting to percolate from each of the subgroups. That's what how I'd like to proceed. Certainly open for feedback or any thoughts on moving forward like this right now from the group. Okay. Okay. Oh, I'm not used to this. Anyway, so like I said, next step, you'll be getting again a follow-up email from William. Again, those of you who are watching this, we have your emails. You will get the information. If you are interested in getting more involved, please respond, and we will look to get you plugged in appropriately.
Senator, I'm sorry, just to make you feel more at home, I actually did have a question. If we filled out the form online, are we automatically going to get into one of the subgroups, or is there going to be a follow-up email for those, or should we just reach out to Will again?
You'll get an email back, once we get the different groups organized. I think, Will, did you receive one from Maggie?
I need to check the form. If I'm not sure if I saw the name in there, but I'll be sure to check that to make sure, and I'll touch base after the meeting.
Sounds good. Thank you.
So, okay. And one other thing too, we'll look to have a co-chair type of system, again, comprised of for each subgroup comprised of a working group member. So that's going to be also part of this as well. Lisa, you still have your hand up. Is that just, I'm just checking, make sure.
I just need to take it down. Sorry.
No problem. I just want to be, just trying to make sure. All right. So let's move into the public comment portion of the meeting. Again, anyone who is participating and wishes to, make a comment, please, I guess, raise your hand, and we will look to elevate you.
So Senator, Ken Bach has had his hand raised, so I'm going to go ahead. Ken, I'm going to enable your audio now.
Welcome, Mr. Bach. I believe you're muted, sir.
Okay, sorry about that.
Thank
Going back to the 30% number as a target for transitioning services from Older Americans Act funding to med waiver. We asked earlier about the geographic disparity. I would also ask that 30%, is that an estimate across all the programs, or some of the Older Americans Act services, funded services, higher percentages, others lower?
Melissa, would you have a?
Sure.
Yeah, go ahead.
So the 30% was an estimate we derived by specifically looking at the personal care recipients currently. And so right now we know that at a minimum 30% of the people that we serve with personal care services today seem to be eligible for Medicaid. We don't have much better extrapolation specifically across geographic regions, however.
Okay, thank you. No, I was more concerned about the program separations, but 30% was based on the personal care. So, thank you.
Thank you, Mr. Bach. Okay, I see Cheryl Heights has her hand raised. So that you elevated, Cheryl.
Thank you. I had a question regarding the presentation that was earlier that talked about some of the village networks and home sharing. Is there any data available on the health status of individuals who are able to participate in those programs?
That's a good question. I don't believe our presenter is no longer on the call. So, but we can definitely, follow up with her and get that information.
I mean, they sounded like really great alternatives for those individuals who are relatively healthy. So I was just checking to see if they've done any kind of data gathering on that side. Thank you.
Okay, well, let's make a note of that and see if we can have a follow up to that. Get the answer to that.
Yes, of course.
Okay. Does anybody else have anyone else who's on like to offer public comment? Okay. Oh, I see somebody just raised their hand. Jamie Ramage. I hope I pronounced that correctly.
Hi, yes, thank you. You did. I appreciate it. I was just curious to inquire about the sliding scale that was referenced with respect to payment for personal care.
For the Melissa, then.
Absolutely. So we are looking at different cost sharing opportunities, and because this is going to be brand new for our services, we want to start extremely conservatively, understanding that whenever you implement a co-payment process that hadn't existed before, it's going to be a bit of a shift for individuals. So right now we're focusing on personal care because it's definitely our longest wait list and also a very needed service. And so for those Delawareans that we're currently serving that have the means and the income to contribute towards their own services, we'll be looking at a fairly modest and conservative sliding fee scale. And we're talking, a few dollars per service, and certainly not, going up to the full coverage in the beginning, at least.
Thank you.
Sure.
Okay. Anyone else from the public wish to offer a comment? Okay. Any members of the working group have any thoughts or anything that they'd like to share? Representative Griffith, were you about to say something? I thought I saw you raising your hand. You're muted.
I was about to say something, but I'll save it. I just was tremendously impressed by our presentations. Especially see what's happening also in other states is just phenomenal. Oh, sorry. And I have like Chris, I have one home today, no school today. So sorry, he's to my right, so he may make a cameo. But I just really enjoyed those presentations, and and like to see sort of out of the box what's going on in other locations to sort of give us an idea of what we can do. That's all. But then I wasn't going to say something, but thank you for letting me say that, Senator. And I appreciate again that I'm excited about this work and looking forward to getting our full complement of working group members together. I think it would also be helpful. I know we're going to have some working group member who's actually a senior living in place. I think we should devote one meeting in the future to hearing those stories of what's happening, you know, from our collective experience to the actual individuals who are living in place, and to have an opportunity to hear their stories and what their challenges are, what's working, what's not working. I think that might be refreshing for all of us to sort of hear. I know we all have our perspectives as caretakers or working in this field, and we of course will have one member who is a senior living and working, sorry, I think I'm confusing working group and you know what I'm saying, aging in place. So if we could focus on those, I think that would be a helpful, that would be a great meeting presentation.
Absolutely. I think that would be really interesting. And I think trying to look at it from different parts of the state, I think, you know, we've got some, you know, thinking about this, you know, there's definitely some regional differences that I think we really need to hear about. And again, I think one of the other topics is, again, the cultural, making sure that we're approaching this in a culturally competent manner. You know, again, the experiences, and as we saw in that graph, you know, when we start to see the differences, you know, when it comes to multi-generational households. So I think that's a really good idea, and just, you know, let's hear from the people who are living it and getting their perspective on this. So I like that idea. Anyone else have any thoughts or comments from the working group? Okay, well then I will give you 10 minutes of your day back. I would like to thank everyone again for participating on this working group. I think I appreciate the energy. I appreciate the interest and the passion that I hear from all of you. And I would like to thank our presenters, even though they are no longer on screen with us. And I'd like to thank everyone who's watching. I think, you know, again, this is a topic that is not a topic that we have to address for the future. It's a topic that we have to address in the present. And again, we want to be as inclusive and hearing from as many folks as possible about how we are looking to address this topic. So please, again, if you are interested, we encourage everyone to participate in one of the subgroups, or just provide, if you have any questions or any ideas or any thoughts, please, you know, reach out to us directly, and either via email, and we can certainly include that. So in the meantime, enjoy the rest of your Friday afternoon. And again, we will look to reconvene as a working group in total 3 weeks from today. And in the meantime, the subgroups will convene and start their work. So thank you so much. And I look forward to talking with you all again in a few weeks. So thank you.